infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Hey everybody, this is Robert, and I appreciate you listening today. And on today's show, we're going to be looking at the autoimmune condition psoriasis and the treatments available now and something that's in the pipeline. And joining me now is board-certified dermatologist and founder of Forman Dermatology and Skin Cancer Institute in Tampa, Florida, Dr. Seth Forman. Dr. Forman, welcome to the podcast, sir.
Thank you very much, Robert.
You bet. Now, let's go ahead and start out with a discussion about, what is psoriasis and how common is it?
Psoriasis is an autoimmune condition which mainly affects the skin. It can also affect the fingernails and the joints as well.
And how common is this in the United States?
The current epidemiology is that it affects around 4% of the population in the world, actually, not just the United States.
Oh, that's pretty significant, actually. Is it contagious from person to person?
It is not contagious. However, the predisposition to develop psoriasis is genetic. It's multifactorial. However, we do know that these autoimmune conditions do run in families.
Okay. Now, I understand that there's different types or levels of psoriasis based on severity, from a slight superficial skin condition to involvement with the joints. Can you talk about that and the symptoms that are involved?
Well, if we want to start with the skin, essentially patients get in the normal areas that you think of, the non-glabrous skin, and if we eliminate the palms and the soles, a normal patch of psoriasis appears as a red, scaly lesion. More severe cases are very thick. Now, if you consider the palms and the soles, because of the nature of those areas of the body and what the skin cells are like, they can get very thickened, but they don't scale as much, and they can cause a lot of cracking and bleeding on those areas. When we consider the nails, you can get pitting of the nails. You can get what we call splinter hemorrhages, which are little drops of blood in the fingernail. You can get detachment of the nails. And then when we're talking about the joints, it's essentially there's five different variants of psoriatic arthritis, from just joint pain or maybe some tenderness and swelling, all the way to having irreversible joint deformities.
Now, a lot of times on the TV commercials for the different drugs, we hear the term plaque psoriasis. Is this a more severe form of it?
Well, plaque psoriasis is the form that we discussed initially. It's what occurs on the normal or the most common parts of the skin, excluding the genital areas and what we call the inverse areas, which would include the genitalia and the underarm areas, as well as under the breasts in women, and also excluding the palms and soles and the scalp. Anywhere else, it's called plaque psoriasis.
Gotcha. So does this condition affect children, or is this strictly in adults?
Absolutely. It can start in childhood. However, most commonly, it occurs in a bimodal distribution, meaning people have their first flare or their first recognition of having psoriasis when they're 20 years old or when they're in their 50s. But there are cases that do begin in childhood.
Okay. And you talked briefly about the genetics of psoriasis. What do we know about the cause or the causes of psoriasis and the different triggers for the flare-ups, or is there just a lot of unknowns to it?
There are a lot of unknowns, but some things we do know, and that's with people with a genetic makeup where they have the HLA-B27 gene, those people are more likely to get psoriatic arthritis. They're also more likely to get other type of autoimmune conditions. We do know that, for instance, say a parent has Crohn's disease, it would not be out of the ordinary for a child to have psoriasis or vice versa. There's a lot of autoimmune conditions that are expressed in different. The autoimmunity can be expressed in different ways in each person. So if you have a family that's prone to developing autoimmune conditions, one person may have Crohn's disease, the other person might have psoriasis, the next sibling or family member might have rheumatoid arthritis. It all depends on how this genetic predisposition is expressed, which is called the phenotype. Not just the genotype, but the phenotype is how it's actually expressed, so and what the human has to live with.
So psoriasis is more than a dermatology issue, but it can also be a rheumatology issue.
Absolutely. This is one of those conditions that if you were to draw a Venn diagram of rheumatologists and dermatologists, there is a sincere and severe intersection of our circles of knowledge for people who are interested in the rheumatologic diseases as dermatologists, which I am.
Right. Now, a hypothetical patient comes to see you at your clinic for this condition. What will the exam and the visit be like?
The exam starts with, discussing when did it occur, what have you tried to make it better, can you tell me what you were doing when this occurs, do you have any family members with a similar type of rash, what is your family history, do you have any autoimmune conditions in your family? In addition to the physical exam, we also do a review of systems, which include any questions regarding joint pain or joint swelling that's occurred in the past. And we also examine the nails as well.
Yeah. And when you make a diagnosis of psoriasis, is it basically based on the physical exam, the appearance of it, and you're a dermatologist? Yes, I know that's psoriasis.
Yes, I would suggest that most well-trained dermatologists, of which I feel we have the best training in the world here in the United States, would be able to recognize a case of psoriasis 9 out of 10 times. Yeah. There are times where it can be very difficult to know the difference between eczema and psoriasis, and that's important because the treatment is different. Sure. And that's when people only have it on their palms and soles. Because even then, an actual skin biopsy is inconclusive. So that can be where it's tough.
Gotcha. Now, let's talk about treatment. And there's a whole mishmash of different treatments out there, depending on the severity of the condition. Dr. Forman, what are some of these treatments available, and how effective are they?
The initial treatment for the milder cases is a episodic use of a topical steroid. That's pretty, that's sort of the ground floor. For patients that are not getting a treatment or the results that they wish to have, we can consider something called phototherapy, which is where people get exposed to ultraviolet B light or ultraviolet A light. I happen to have both, so I can choose. However, most people try ultraviolet B light first if they opt for phototherapy. Phototherapy isn't as vogue as it used to be because you have to go to the office 2 to 3 times a week, and because the way insurance is these days, it's rarely covered by insurance. So it's not as in vogue. As we go up the therapeutic ladder, once patients express that they're dissatisfied with either phototherapy, if they've tried it, or the topical steroids, then, or if they have joint pain or any signs of psoriatic arthritis, because we have to remember that phototherapy and topical steroids don't help any of the symptoms of psoriatic arthritis, as well as they don't help the nail disease either. At which point you have to consider systemic medications. And there's no question that the initial golden age in psoriasis occurred when medications such as infliximab, which is known as Remicade, etanercept, which is known as Enbrel, and adalimumab, which is known as Humira, initially came out probably between 15 to 18 years ago and revolutionized the therapy for not just psoriasis and psoriatic arthritis, but many of these drugs are also used for other autoimmune conditions, which makes sense because genetically they're very similar. they're used for rheumatoid arthritis, they're used for Crohn's disease, they're used for ulcerative colitis. And that's when the consideration for a systemic therapy is really, really important.
Okay, now let me switch gears a little bit. And I understand that you are conducting trials on an oral psoriasis treatment, which is none of the ones that you mentioned are oral. Am I correct?
Correct. None of the ones from the what I consider the first golden age in treatment of psoriatic diseases. Remicade, for instance, is an infusion. Etanercept is a injection which you take once or twice a week, depending on your dosing. And Humira you use as an injection that you do every other week.
Okay, so can you tell the audience a little bit about your trial and the name of the drug or whatever information you can divulge about it? Right.
Well, what we've recognized and what the pharmaceutical companies have recognized is that people don't like to take shots. People seem to think that they feel sicker if they have to take a shot for their condition versus a pill. So there's a whole new generation, what I'm going to call the second golden age in psoriatic diseases, with something called JAK inhibitors, Janus kinase inhibitors. In fact, most of the medications which we have under clinical research don't even have names yet. They still have just molecular numbers and letters that were assigned to them. But what we're finding in phase 2 and phase 3 trials is that they're extremely safe, they're extremely effective, and patients much prefer to go on a oral tablet or an oral capsule than take an injection.
So is the mechanism of action the same as the injectable drugs, though?
The mechanism of action is actually they're smaller molecules than what you get via injection, in fact, and they're even more specific, and they block so much more of what we consider the bad autoimmune response or the inflammatory response without creating such a uniform immune suppression that we're worried about what we talk about often here, which is the rise of an infectious disease or even worse, possibly a malignancy.
Right. And if someone is interested in participating in this trial, is there a way they can contact you or contact the clinical trial office?
Yes. We can be contacted at 813-264-2155. You can also go to forwardclinicaltrials.com, or you can go to Forward Clinical on Facebook. We have a number of ways that people can contact us.
And how far along are you in the trial right now?
We are still accepting new enrollees for the psoriasis trials. We also will be having eczema trials. It's really, I consider it the next golden age in therapy for the psoriatic diseases.
Very good. All right. Is there anything, Dr. Forman, that I didn't ask about that you wanted to add?
No, I think that you've asked a lot of great questions, and we're a very, very open practice. I love spending time with patients and their families. So, if anyone has any questions, or more importantly, if you find, because this happens in my family too, a lot of times you have the husband coming in to do something, but you have to make sure that the wife is okay with it. So we welcome, a spouse to come in and ask questions too, because this is important for them.
Sure. All right. Well, some interesting stuff going on, and I want to thank you, Dr. Seth Forman, for your time and expertise once again. I appreciate it.
Thank you.